Hello and welcome everybody to another exciting episode of Sci Talks 2.0. Today, once again, I have my guest, Dr. Priya Soni here to discuss some of the advances and the questions that you guys had in regards to the pandemic. We will make this an informal discussion, sort of a debate. I'll try to take the opposite side just to have this discussion going based on the questions you guys had been asking that you want addressed. So without further ado, if Dr. Soni, can you please kind of quickly introduce yourself again for those viewers that would be their first time watching and kind of remind the ones that already know you to kind of get a refresher about who you are. And after that, I'll start with the list of questions people have had.
Great. Hi, everyone. Thanks for joining us. My name again is Dr. Priya Soni. I'm a pediatric infectious disease specialist and have really just been enjoying these discussions we've been having every week, and have been enjoying your questions that you're submitting as well. So thank you so much for joining along. And, I'm learning as you all are learning at the same time. So all of us in infectious disease, again, this is sort of like our Super Bowl season prolonged. Like I said, this is a marathon that we are all in collectively. And I hope that this session will be helpful for you to understand from an infectious disease standpoint.
Wonderful. You've been great with helping me in terms of transferring the information in a scientific and medical way. So people have definitely been appreciating that. Now, having said that, let's start off with one of the major questions that people have had, which is how long is the virus going to last, and how long should we expect this kind of lifestyle to continue? And you and I had discussed a science paper that just came out that tried to model roughly what is the let's just say post-pandemic period of coronavirus and what to expect for the next 5 years. So can we just touch upon that a little bit and get some sense of what to expect? Because a lot of people are getting antsy and wanting to leave home and start working. And what are the measures that we need to start initiating before all of this can happen? So let's start off with the science paper and then we could transition over to that.
Yeah, so the science paper is actually a little bit alarming even for me, and reading that and reading about the suggestion that this may go on until 2022, 2024, and that we would need to implement these strict social distancing measures in order to fully contain this virus. I'm an optimist, and everything about the projections and the numbers that some of the experts have predicted from modeling have been much less than what the worst numbers were, I guess. And so I hope that our early social distancing efforts, many of us in larger cities, we've been cooped up now for over almost a month now, officially. And it's hard to say, like a lot of people are saying, we have to see numbers improve. So before we make any projections, any specific dates that are laid out there for people to hang on to, I think it's just like, like bait that these people on the news are kind of putting out there as headlines as, okay, May 15th, no, May 30th. Like, we don't know exactly what that date is going to be. But I think there are a few key things that you were alluding to that would be really important for us to see collectively as a society before we loosen up in some ways. It cannot be this complete reversal of all of the restrictions and social distancing. It must be a very thoughtful stage approach to when we can start resuming some of our normal life behaviors and gatherings and whatnot. So I think from my perspective, and in talking to many other experts in epidemiology and public health, many experts in emergency preparedness, one of the main things that we need to see first and foremost is that the number of new cases is decreasing. So every day, we see ramping up of testing, et cetera, but we need to see that the cases are now dropping off. And they're not just dropping off for a day or two. We're seeing consistently every single day in whatever city everyone's in, the cases are dropping off, steadily over at least a week or a 2-week period. And then, simultaneously, many other things must be happening at the same time before we return. And that includes we need to be able to have testing. Testing is now even more so in a wider scale than it's been ever before. But we need to get to a point where testing is readily available for someone with mild symptoms, and they can get a test result back with a PCR swab within less than 24 hours, which means they're not.
Sorry, not to cut you off, but practically speaking, right, we're not going to be testing all of America. I mean, that I think is almost an impossible feat to do. But what you're saying is those that are either high risk or there's very high suspicion, or as in the medical community, we say a high pretest probability, should be tested. And we need the answers back right away, because if it takes a week for the test to come back, then during that interim period, the person who might have been tested negative could contract it. And now the test result is giving us the wrong answer.
Right. And so right now, if you think about how we're testing people for SARS-CoV-2, if you're really, really sick, you get the test. You know what I mean? And then if you're a healthcare worker, it's easier for you to get the test. If you're a vulnerable host, it's easier for you to get the test, right? So we need to be able to scale that up to anybody. So we are able to test you with mild symptoms, even a mild runny nose, fever, and we're able to really identify and isolate these people. And until we get widespread testing in combination with case tracking and having the public health capabilities of contact tracing in place, along with the appropriate supplies. We need our supply chains for protective gear to be really ramped up and available to be sustained. Until we get like a couple of those, those pieces in place, and along with the steady decline over 2 weeks at least in areas in high, population dense cities, etc., New York, LA, Chicago, then we can start thinking about how we can start moving towards opening maybe some more essential businesses, and implementing strategies within schools so that we can provide social distancing within schools, etc.
So the summary is that the science paper is alarming. Again, it's still a model. We've been wrong with models a lot, but if we take it to be somewhat reliable, it's saying that the coronavirus is going to happen in a seasonal fashion until the next 3-4 years at least. And the only measures we have right now is social distancing and quarantining until we get a vaccine, which is something else we'll discuss in a minute. But that'll take 12-18 months. So in the meantime, we need to continue maintaining this. But as we both know, it's not very practical. But you're saying before we allow the faucet to be kind of loosened, we need certain factors to be guaranteed before we even think about it, right? Whoever it is that's saying we need to loosen the faucet, they need to hold off on this until larger scale testing is possible, contact tracing. Now, when you talk about contact tracing, what you're saying is once we know there's a small breakout, we need to quarantine everybody that was involved. That way the virus doesn't have much room to spread. Is that what you were getting at?
Right. So really, this is a very key element. It has to be the capacity for every state to do rapid case finding isolating those pockets and then contact tracing for case management needs to happen. We need to be able to have the manpower to implement that in every state. And I think that's going to make things a lot safer um, before states start beginning to relax social distancing policies, etc. So I think you know, if you loosen the brakes right now, it's sort of analogous to riding a bike down a hill, and you have you have some protection, like you have a helmet on, but what's the point if you don't have brakes fully in place to make sure you have a safe landing? Um, and I think that we can go back into a spiral where things get really, really bad very quickly if we don't have a lot of these safeguards in place.
So with those safeguards you're talking about, we need more testing, we need more manpower. Maybe this could open up more jobs for people that, are in a healthcare field in some ways, that we need more people to go into this field to be able to provide all of that. So it could be job opportunities for certain people, right?
Absolutely. I mean, I think that would be a huge, avenue for jobs. I mean, people are sitting at home, and this would be a great way for them to help. Um, it's not even that we need, I think in my eyes, it's like we need the manpower, not necessarily even you have to be trained in public health, etc. We need the people to go house to house and do a lot of the things that many countries in Asia are doing, including Singapore and South Korea, etc. So I think that's a potential avenue for our future, and um, there's a lot of room for many companies that are already in place to think about some of these strategies and start pivoting from their plan to other
Mhm.
creative solutions.
So, like you're saying, become creative. And, one other thing that you had mentioned is protective equipment that needs to happen. And this is, we'll touch upon this, but maybe if you were uh, making something else, not there's a huge need for something else, which is protective equipment, change your manufacturing, right? And so people could find jobs in a newer market that's just opened up in terms of places they could work and things that they could do and could be easily trained to do this. So uh, this could, you know, fix the hole in the economy to a certain degree by reallocation of our resources to something else that is a bigger problem. And I think where there's a problem and there's going to be a solution, and with solution hopefully comes with creativity and entrepreneurship and job opportunities.
Yeah, absolutely. And I think we owe it to our healthcare force and to have proper personal protective equipment there for them, and we're still in the thick of it. We're still in crisis mode right now. So we need to be able to shift resources and allocate, resources to these critical areas and fix our issues that we have with the supply chain, with PPE acquisition, and
Right.
make sure that every hospital has enough before we even start lifting social distancing, etc. I think that's a really important thing to think about.
So when it comes to PPEs, I know I've been getting questions about wearing masks. Some states have made it mandatory. You're going to get a fine for it. Other states are kind of more relaxed. It's only a recommendation. And I know this is state by state, depending on how bad the situation is. But what's your recommendation or for our viewers, what should they be doing from a medical perspective? I know they have to follow laws and regulations. That is definitely the case. But what's your medical sort of, if you were to put the politics aside, recommendation be in terms of masks at this point in this stage of the pandemic?
Yeah, I mean, just putting aside everything, I think the the benefit of wearing a cloth mask outweighs the downside when you're looking at the science of things. I mean, obviously we know it's not as effective as having a surgical mask, etc. N95 masks, of course, we want to really reserve them for healthcare workers, etc.
Mm-hmm.
But at this point, we are expecting people who feel sick to stay at home, and so wearing a mask isn't going to wearing a mask is really helpful because there's sufficient evidence to suggest that there is asymptomatic and early pre-symptomatic transmission of this virus. So if you have to go outside and you have to go to the grocery store, wearing a mask and preventing potential spread the benefits outweigh the downside of such coverings. And I think we'll see more and more use of masks. I think we might become like some of the Eastern Asian countries where we see just normal mask wearing even pre-pandemic with COVID-19. So it is an individual form of source control, but of course it has its limitations.
So kind of shifting gears in terms of that, the two main things I want to talk about are vaccines and specifically the BCG vaccine. I know we have some exciting stuff about that. And also the testing modalities. We talked about large scale testing. Now there's the serological tests versus the PCR and what different information each of these offer. So let's start off with the vaccines first. We know we're about 12 to 18 months away from potentially having a, excuse me, coronavirus vaccine, right? But in the interim, for our stopgap, there's been some exciting stuff with the BCG. So can you tell the viewers about some of the clinical
Yeah.
trials that have been initiated and what does that mean in terms of acting like a stopgap?
Right. So I'll just say a little bit about the vaccine for COVID-19. Right now we have multiple companies that are sort of working on this, and we have one phase 1 trial that has started already in Washington State. So the phase 1 trial is, a safety trial. We still have to get through the phase 2 and phase 3, and this is, creating a vaccine takes years, so this is something that is unprecedented, that FDA has really started these trials up so quickly. So that's something to be, very hopeful about. But that being said, we're still, like you said, 12 to 18 months away from really knowing how effective it is. Now, FDA does have some emergency sort of protocols in place where if we find enough evidence over the summer that this vaccine, the Moderna vaccine, is efficacious and it is producing some immunogenicity against this virus, then there are some emergency acts that FDA can implement to approve it in high risk individuals in the healthcare settings by this fall. So that would be like the earliest, right? But what do we do between now and then, or now and 18 months from now when it's available to everybody, right? So one of the really interesting things that has come from this whole pandemic is rethinking about some innovative ways that we can approach this infection. And one of them I find very interesting is use of BCG vaccine. So BCG vaccine is a live attenuated tuberculosis vaccine. And it has the ability to induce this non-specific cross protection against many pathogens, sort of that are unrelated to the target disease of tuberculosis, but it's able to provide protection, for example, not just against TB, but for Candida albicans, for Staph aureus, certain scenarios where it's even proven effective for respiratory viruses like human metapneumovirus. So how it does this is by inducing your innate immune cells. Your innate immune system is very different than your memory B or T cells. Um, they the innate immune system is pretty much your trained immunity. So we can increase your body's ability to respond to a pathogen by reprogramming it, and making your immune cells, like your monocytes and your natural killer cells, more apt to handle a novel pathogen, possibly like COVID. So I think there are a lot of different countries right now, Australia, Holland, the United States, looking into the potential use of BCG vaccine in protecting those that are at highest risk for contracting COVID. So healthcare workers, I think this would be a very interesting population to try this vaccine. Now it's a live vaccine, so we have to be careful.
What if you've already been vaccinated, like this guy, because of certain countries that were continuing to maintain the vaccination of BCG, unlike the United States, there are some countries that still do it. I know there are some Asian countries that are still doing it. In fact, they even give boosters. Are people who've gotten it when they were younger protected? Not, I mean, again, this isn't to say the answer is 100% and that people shouldn't continue doing the recommendations. Even if you've got the BCG, doesn't mean you're immune to it. But are there some level of protection provided if you've had the BCG vaccine before?
That's a great question, Akop. And I actually also have had the BCG vaccine when I was younger in India. So I think that it's an interesting question that I don't know how to answer yet, because most of China, they mandate the BCG vaccine, but we've seen that, we've seen hundreds of thousands of cases in China. And then Italy, for example, they do not routinely get BCG vaccine. So I don't know just yet how to answer your question. And I think that's part of the, what we're trying to figure out as scientists. But I think it would be a very interesting question to ask if sort of looking at retrospectively over time, the next few years, are people that have received BCG when they're younger, are they, if they do get COVID-19, would they have a milder case, for example? I think these are really interesting questions that are coming from all of this. So something to look out for.
Maybe we may need like boosters to start the immune system, even if you've had it. But active vaccination right now is something that is being clinically tried, and hopefully it works, because even if it gives some level of temporary protection, it could allow them to gain the memory, adaptive immune system to help with the long-term protective immunity.
What it does really is it induces changes in the methylation patterns of histones, and then those histones are associated with certain genes in circulating monocytes. So then in turn, it's been said to train your immune system in a different way. So I think it's just really fascinating. I don't know if it's going to work yet, but I think it could be a potential, we could potentially use this in the interim period.
Sure.
While we're developing an actual vaccine. And, if you think about trained immunity, and this is something that's not specific to BCG vaccine alone, I think a lot of vaccines, even the MMR vaccine, has this sort of trained immune response that I think is quite interesting. So more to come on that.
Yeah, but it's definitely an interesting, and I know there are some epidemiological studies putting a lot of weight on this. So let's sort of cross our fingers that this could sort of act like a stopgap. But so in terms of detecting people who've had exposure and cleared it, serological testing is the way to go. So can we compare the serological test with the PCR, what information it offers, and how the serological exam could potentially be one of the keys in terms of rolling back our normal lives in stage-wide stage-wise fashion, right? Especially kids that want to go back to school. You know, I'm getting a lot of teachers and educators asking, well, when are we going to let kids go back? And you know, kids are not going to be that that good in terms of not touching their face, putting masks on, and keeping a social distance. So I think we need solutions, and serological testing with PCR testing, getting a snapshot of what's going on in the public is one way to go about it. And so, can you talk about the serological tests and what it offers and what are some of the hindrances?
Yeah, definitely. So, one thing I'll just start by saying is that a serological test is not a diagnostic test, right? So, it's not like the PCR test where you get a nasal swab and you are able to detect the RNA of SARS-CoV-2 virus in your nares, where it preferentially replicates. An antibody test or a serological test checks for an IgG and an IgM. And it shows whether or not someone was previously infected. Um, and, and sometimes, even if a person didn't show symptoms, it can detect whether or not they were exposed to that particular infection, right? So, what does that translate to in real life? It's really hard to say. We know that the immune system sort of functions on a continuum. So, like if you check your antibody to, varicella zoster virus, for example, that causes chickenpox. If you have antibodies to chickenpox, that causes sort of like a universal, long-lasting resistance to that infection, meaning like you're protected for life. Um, when we start to check for serologies on SARS-CoV-2, we don't know a couple things. We don't know, how much antibody is going to be protective. So how much IgG antibody response do you need to mount to protect yourself from potential reinfection or another episode of SARS-CoV-2 in the future? We don't know the level. And number two, even if you are protected and have this magical amount of IgG present in your blood, we don't know how long that will necessarily protect you. Um, pretty much all infections give you an antibody response, but we don't know what it means. So we have to kind of answer some very key questions about how long does this immune response last? And at what level would you see appropriate protection against reinfection? When you look at immunity to seasonal coronaviruses, so the coronaviruses that cause like the normal cold, those antibodies start declining after a few weeks from infection. But when we look at like SARS, for example, SARS that peaked in early 2000, antibodies against SARS were a little more promising in that the immunity peaked around 4 months after infection, and it lasted for about 2 to 3 years. So
hopefully that's a good sign that the SARS-CoV-19 would also last that long and provide some level of immunity. And just for the viewers, I just wanted to briefly mention that the PCR testing tests for the viral genetic material using a method called polymerase chain reaction. And the antibody serological test is testing your body's immune response against the virus. So it's like looking at two sides of the same coin. One is your body's immune response in building the antibodies, and the other one is the actual viral genetic content. And this is why there might be discrepancies in terms of not being able to test for the virus, but having antibodies, because the virus could be long gone. You can't see the genetic information, but the antibodies you form could still be there. And as Dr. Soni said, hopefully these antibodies last longer than the general coronaviruses, so that we could produce some level of protective immunity against that. Correct me if I'm wrong.
that's totally right. And I love that you know, clarified and made that distinction. And one thing I'll add is that we don't know, like, because we can detect the virus via PCR in your nares, but we haven't seen any correlation between people who are super shedders of the virus, meaning that they have high viral loads, and if they subsequently develop equally high amounts of IgG or IgM to the virus. So we don't know that yet, and we don't know that correlates. So just because you have very severe SARS-CoV-2 infection and, you know, very severe course doesn't necessarily mean that you would mount an appropriate, equally robust
Immune response.
antibody response. We don't know.
Right.
And also, like, you know, people that survive SARS-CoV-2, you know, is there something about their antibodies that are different than people who get SARS-CoV-2 and unfortunately pass, you know?
Right.
So I think there's some very interesting questions that we, you know, are still teasing out here.
Of course, not to get too detailed, but we know there's affinity, avidity, different antigen motifs that the antibodies could be built against. So all of these could be really important in dictating the outcome. And it's an answer we're not going to have for a while until enough people have been screened. So this goes into, you know, the phases of transitioning back. Like there's a bunch of really important and key questions that will take time to answer. I mean, weeks or months. And until we have these, we need to not go down the mountain with our bicycle just yet, right?
Exactly. I totally agree with you. It has to
uh,
be a very rational, you know, stepwise approach. And we have to get out of crisis mode. We have to see that the first step is to see that steady decline in new cases every day. You know, whatever city you're at, you should check your local public health websites and just see if you're getting to that point where you're starting to plateau or not quite yet. So I hope that that time comes soon for all of us.
and you know, everybody's talking about herd immunity, but based on numbers we were discussing, we're far from removed from even acquiring anywhere close to the herd immunity, even if we test everybody in the population. So I think we should, I know it's hard to ask people to be more patient than they have, and people have done an amazing job of trying to contain themselves, social distancing, but I think we need to be a little bit more patient until we have some of these answers at bare minimum, right? Before we could even consider the initiations. And you and I discussed, you know, really briefly, Gavin Newsom about his 6 stages, and I think it's a little bit too premature to even discuss those, right? Because there were some points in there that is it really practical to do some of these things, like redesigning schools to keep kids in certain places and change the playground? But even before that, we need these bare minimum answers.
Yeah. And if you think about it, you know, social distancing is literally the only weapon we have against this pandemic and this virus right now. So to take away our only weapon in the midst of a battle would be really foolish to do without really some safeguards in place, like we talked about earlier.
But people are also going to say, Dr. Soni, great, but all your models have been way off right now, and the number of deaths are not even close to the people dying from heart disease, cancer, and all of this other diseases yet so far. And knock on wood, let's hope it stays that way, because I would love for all of us in the medical field to be wrong with our models, overestimating it. But what evidence do you have that social distancing is helping, and that I should stay home while you guys go to work? And what evidence do we have that that's our only weapon? What do you say to that?
Well, I think, you know, you have to look at the data, and the numbers are clearly showing from certain areas in the country, like San Francisco, for example. The population density of San Francisco is quite similar to New York City, and really the early social distancing has caused that curve to flatten, along with the entire state of California. So when the social distancing efforts were put into place, we knew that it would be a long game, and we knew that it would take weeks for us to see the benefits of that. And I want to be wrong. Like, please prove me wrong, because then that means more people are alive and more people are well. So if we over project, it's better in the moment than taking things too lightly. I think that's the approach. You have to, move with cautious optimism with every single win that you have with this, but also, you know, I'd rather be proven wrong and overreact to this. And I think most infectious disease specialists would agree with that.
I think of it as the results of doing our social distancing is something people can see, because if you saw the results, it means people were dying, right? So it's a little bit hard for people to see why it's working, because when it works, you don't notice it that it's working. Just like taking your blood pressure medications, right? You don't see that it's working until you stop taking it and see the consequences of that. So I think people should uh, maintain this attitude that it's working and therefore I'm not seeing the results, because if I saw the results, it means there was something not doing right?
Yeah, absolutely. And, this is very different than any other virus, respiratory virus we've had to deal with in the past. When you look at the numbers and compare influenza to COVID-19 in terms of the length of hospitalizations, the burden on our healthcare system, the patients that are requiring intubation, the patients that are end up dying from this, it's very different, stark difference. And a lot of the patients that do end up intubated from this infection end up in the hospital intubated for weeks on end. And every single day, you and I know, every single day a patient is intubated on a respirator. The likelihood of them, coming out from that, it gets
Grim, yeah.
much lower day by day. So I think there are a lot of ways where a lot of reasons why this is very different than anything we've dealt with before. So there's no quick fixes, and we have to keep reminding ourselves that we're all in this together. And it's definitely a marathon that we are in the thick of. But we just got to keep going and remind ourselves that there will be a light at the end of this tunnel.
And so what, a couple of last questions before we end this, so that we'll have some questions later on for the other shows. But one is reinfection. I know this is a topic that keeps coming up, but I generally don't think that there's any current solid data that there's reinfection. What's your take on that?
Yeah, I get asked this a lot, and the case reports of quote unquote reinfection have been in situations where the patient recovered from a clinical standpoint, but then was retested within several weeks, and the PCR was still positive. Remember, PCR detects viral RNA of this virus, so it does not tell you whether that virus is viable or it's just, virus that is sort of like dead virus that's not capable of replicating and invading your host cells. So I think if you showed me somebody that was infected with this infection in December and then they were completely well, and now in April they have a new infection a few months later, I'd be more convinced that reinfection is something that could potentially happen. But I'm not convinced. I think that the few cases we're seeing were probably just patients that were intermittently shedding or had prolonged shedding of virus.
So we shouldn't be concerned about reinfection just yet. And then the last question that I wanted to sort of touch on is kids going back to schools, and should parents be really worried if when that happens, right? In terms of transmission and bringing them back home, what's your take on like when we should allow these? I know a lot of parents are anxious to let the kids go to school just because they're the sick of homeschooling, and I say that all jokingly. But what do you think the sort of timeline would that for that be, or should we expect homeschooling to drag on a little bit longer?
That's a great question, very loaded question. I mean, I think schools are, and children, and I'm a pediatrician, I mean, children are uh, very interesting group and subset of COVID patients because they have such mild infection and they're really potential carriers and spreaders of this virus in ways that we don't fully understand just yet. If we had data to say that, okay, you know, only 2% of children are asymptomatic shedders and the rest do have symptoms, for example, then I might feel more comfortable sending kids back. But you know, we still don't know that information. So it's too dangerous for us to send everyone back to school when potentially they could just perpetuate this infection and to school, to teachers, to parents, and just kind of be. We know that schools, daycares, they're very much like an incubation, you know,
Mhm.
like a petri dish for infections. So I think we have to be mindful of that. And until we have more data on pediatrics, we have to be careful.
All right, awesome. So in summary, we shouldn't be discussing about any actual days of reopening, going back to normal life. And you and I agree that normal life isn't going to be pre-COVID era normal life. There's still things that need to be uh, maintained, even in the setting of a vaccine that we should continue doing. And also, hopefully, the BCG can sort of be a stopgap in the meantime, and we shouldn't be too antsy about transitioning back there to the pre-COVID era just yet. Does that summarize?
That summarizes it really well. And one more thing we didn't really talk about this time was that we still don't have a good treatment for this infection. You know what I mean? So it's like even before we get to a vaccine, before we open up society, we don't know what stops this infection. And there's so many um, therapeutic drugs that are being thrown out and used. And we still don't have good randomized controlled data to show that, okay, remdesivir works or hydroxychloroquine is actually very effective. I mean, we still don't have concrete evidence on these things. So I echo everything you said in that, and we still need to figure out a lot of these key gaps in knowledge.
Yeah, and that's just going to take time, as much as people are working on it, day and night, literally, we things just take time for to happen, and we got to be a little bit more patient. And I think people have been very patient, and we've got to all tap ourselves in the back for doing the right stuff. So I congratulate for the general effort on the population level. And having said that, I want to thank you again for coming on. It's been awesome discussing these things, and I know a lot of people appreciate the honest discussion, putting politics and agendas aside, just looking at science and medicine and just the hardcore facts. And sometimes the hardcore facts might not go well with what we want and what we feel and where we wanted it to be, but it is what it is, and sticking to that is, I think, important in helping make decisions on a population level. So I want to thank you for that. And if you have any last few words or anything that I might have forgot, please.
No, I just wanted to say thank you again for this opportunity and looking forward to answering more questions and, you know, doing this again in the future.
Thank you so much. And hopefully next time we'll have some updates on cool drug developments, crossing our fingers. So with that, everybody, I want to thank you all again. And if you've enjoyed this, please don't forget to smash the subscribe button and the like button. And we'll see you guys next time. Again, thank you so much, Dr. Soni. I want to wish you a wonderful rest of your night. And I will see you with everybody in the near future.
Take care. Thank you so much, Jacob.
Bye.
Bye.